Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler, and welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is senior depression. With me in the studio is Dr. Joel Shuy, who is a clinical psychologist, and Lisa Conway, registered nurse for Wuesthoff Health Services. Today, the show on senior depression is extremely important. And if you've missed a part of what we've said, if you go to our website, you can pick the show back up and see what Dr. Shuy and Lisa are saying. So, welcome, Dr. Shuy.
Thank you, Joe. It's good to be here.
And welcome, Lisa.
Thank you.
You know, we've done a show before on depression. Mm-hmm. So, it is a topic that is most appropriate today because there are so many things with the economic situation in the country, with unemployment, with people worrying about things. I think there's a tendency, especially for seniors, not knowing what to expect. Depression is something that's extremely important. And I want to make the point, and I know that you both want to make the point, depression is not part of the aging process.
That's correct.
I'll make sure. Now you can talk. What is depression?
Depression is a set of symptoms that where if an individual has enough of these symptoms that we would consider it to meet the criteria for a diagnosis. There are different types of depression, but the one that most commonly is talked about is major depressive disorder. I can go through some of the symptoms if you'd like. But
we're going to do that, but
okay.
I just want you to go over what depression is and make so people understand it's just not normal. It's a dangerous thing if not treated.
And I think there are several reasons why depression is so important to talk about. One is that it's often underdiagnosed and it's missed often even in medical settings. So there's needless suffering that occurs because people could be treated for it successfully. It is a very treatable disorder. The other thing is that the rates of suicide are very high in older adults. But in general, I would say that depression is a set of symptoms that is beyond simply feeling sad or grieving. I mean, those are normal experiences that people go through.
Yes.
When we lose a loved one or when we retire, we may have some mixed feelings. The depression really comes into play as a diagnosis and a disorder that needs to be treated and paid attention to when these symptoms persist for an extended period of time and really begin to disrupt daily functioning in significant ways.
And you know, Joel, even in the family, one half of that partnership quite often fails to recognize the signs of depression in their loved one, in their partner. They don't see it.
Yeah, I think that's very common, there's some generational differences in acknowledging perhaps the importance and acceptance of talking about feelings or talking about suffering, but there's different families have different styles of dealing with emotions, but I think particularly with many older adults, there's a pull yourself up by your bootstraps and You can tough it out and work through it, or have more faith. There's all sorts of things that we want to encourage people to do, hoping, really, and with all good intentions, hoping that will work and help them get better.
Yeah.
But we know that it's more complicated than that.
Yes, it is.
So there is a certain amount of denial. Really, with a lot of the other illnesses we've talked about dementia in the past, and initially there's that same sort of process that goes on within a family, where we don't want to see things that are painful, and that we don't know quite what to do with.
Yeah, and you and I, I'll get that right with it. Me and I, we are more prone to do exactly what you just said than Lisa would be. What I meant is, we would be more apt to to ignore this thing, whereas Lisa, as a woman, would be more apt to express. And that's in all my readings about depression. It's one of the things in the major difference between men and women. Men try to hold women in, and women are willing to openly express it. Is that what you see, Lisa? I
do see that, and I think that what's really important, especially in the males, is if you look at the statistics, men are 4 times more likely to actually complete a suicide than a woman also. So I think it's even more important sometimes that we recognize those signs and symptoms in the men, and we do try to address those, because again, they may try to hold it in and kind of deal with that in a more permanent way.
Okay. Lisa, I sort of ignored you when we started. I got talking to Dr. Shuy, and we got off into what this depression is and isn't. But what is your job? What do you do in this part of this senior depression type thing and depression here in the hospital system?
My job is to go into the community, to talk with law enforcement officers about depression, about mental illness, to talk with the staff in the nursing homes, in assisted living facilities and other hospitals, to kind of help the caregivers be able to recognize signs and symptoms of depression and other mental illnesses.
Okay, let's just, both of you, since you mentioned it, you start, and then Dr. Shuy, you do. Let's talk about the symptoms of depression.
Okay. There's a lot of symptoms of depression that are common in both the elderly and the rest of society. But what we need to know, especially with seniors, is that oftentimes with depression in seniors, they might not describe how they're feeling as being sad. What you might notice is they may be more irritable. They may start to kind of back away from things that they used to enjoy doing. If they used to like to garden, you might see that they're pulling away from their gardening and just spending more time inside. You may see an increase in appetite or even a decrease in appetite. You may see some sleep disturbances, not able to sleep or not able to fall asleep. You may see some weight loss, weight gain. What else, Joel?
Certainly many of those physical symptoms of like you were mentioning, sleep, appetite disturbance, feelings of helplessness, hopelessness. Certainly the withdrawal from others, the social withdrawal, is a huge thing that keeps showing up in research.
I think it's important, too, that people know that there are physical symptoms with depression. Pain can be a symptom of depression. Some GI upset or gastrointestinal upset can be a sign of depression. Headaches, increased headaches, and things like that. So it's important for people to realize that there are physical
what I'm hearing both of you say is what I've heard Debbie Whitnable, who runs your cardiac rehabilitation center, and Dr. Hong Zhang from the Brevard Vascular Institute, and a couple other people, and your other hospice members of your hospice team have said that there are many signs of heart attack that people don't recognize. There are many signs of depression that people don't recognize. And I saw you, Dr. Shuy, looking at my research notes from what I did before we went on the show.
I'm sneaky. Yeah.
One of the things that I had underlined, one of the psychological factors was fear of death. And in senior citizens, as we grow older, as much as people might not like to think about it, it is inevitable that we will die. And how one accepts that transition from the life to the death stage is often a cause, I think, for depression in seniors, because they become depressed about thinking about dying. So my thought for that is do something that gets you involved. Dr. Shuy, in thinking about the fear factor, I would estimate that many seniors, as we grow older, fear the unknown, and I would think that this might be one of the greatest sources for depression in seniors. Absolutely,
and it ties into a main dynamic or factor that's involved with anxiety as well as depression, and that is the sense of a fear of losing control and loss of control over many things. And as we are losing functions, we're certainly reminded of that. Death will pop into our awareness from time to time. Certainly losing friends and loved ones with greater frequency as we get older. I think to counteract that, certainly moving in the direction of living and living vigorously to the extent that we can. We may not have the same physical capabilities. I certainly don't, compared to when I was 20 years old. And we may have other aspects of our functioning that aren't quite what they used to be. But in many other ways, we're wiser, have more life experience, and I think more to give. So having a connection to the community and a connection with others and some sense of meaning and purpose is critical for combating the whole idea that everything is slipping away from us and I don't have any control over everything. And basically focusing on what do you have some control over.
Exactly right.
So,
I always, in conversations like this, I have an example of when I come in the Navy's retirement home in Gulfport, Mississippi, my last job in the Navy, I had a program there that everybody that worked, I paid them $50 a month. I had a small contingency fund I could use for that. And I had guys that put a backpack on, had a blower system on it, and every day they came out the front door of the home and the street all the way out to Beach Boulevard, they blew the leaves off. But I had another lady. She was 94 years old, a professional secretary, Phyllis. She ran the social service department desk. 8 hours a day, 5 days a week, at 94 for $50 a week. Now you might say she was undercompensated, but the feeling of belonging, the feeling of contributing overshadowed anything. She didn't work for the money, she worked because she wanted to be involved. And that's what I find with your pink ladies at the hospital. You find this in the people at Patrick Air Force Base that work in the pharmacy and hand out all the pills and work in the clinic over there. Hospitals and clinics and many of these functions couldn't exist without volunteers. Right. But those volunteers give a person a reason to get up in the morning, and it tires them out enough to where they can get a decent night's sleep. So, I think, and when we get into the depression, what else, Lisa, would you add to what that Dr. Shuy and I are saying? Because you're the marketing person, you go out in the community, you talk about this at health fairs and things, right?
And I think that's very important. I talk to family members too of people, who may be concerned that their family members showing some signs of depression, and that's always one of the things that I encourage. Maybe being a pink lady at a hospital isn't the right volunteer work for everybody. But, look at other options, going into their church or something like that.
That's another great source, yes.
Just having that feeling of belonging and giving really kind of helps. Again, you feel like you have some purpose. Especially.
Yeah, it's kind of like the old thing, when we think of the tithing business in the Bible and in the church, we talk about giving 1/10 of your treasure, and I talk about the treasure of your time, talent, and giving of yourself. People forget about that. We can give ourselves to others in community service, and it's nice to know that depression can be treated, and we can do a lot. But a lot of depression treatment, I think, Dr. Shuy, evolves from the ability of doctors to involve family members. A question I've never asked a doctor. What is your opinion on the use of family and medications? How do you balance the two? And that's not an easy question.
Right. And I could try to sidestep this one gracefully by pointing out, as a psychologist, I don't prescribe medications, but I think I can do better than that. I certainly believe when it comes to certain types of psychiatric disorders, and particularly if somebody is significantly depressed to where they're starting to have some cognitive deficits, or they're more forgetful, and they may the very things we need to do to feel better and get better. With depression, a lot of times the depression keeps us from doing that. So maybe even remembering to tell the doctor certain things that are very important, so that they could help adjust our medications, maybe lost as a result of the extent of the symptoms that they're having. So I think there are some confidentiality aspects that need to be addressed with that. But I think if a physician that is prescribing the medications makes it clear that from the beginning that bringing in your family members at least every other visit so that I can check in with them is important. There are some physicians who will read faxes that family members send, or ask for updates that they can include in the chart, and maybe have a nurse in the office review some of the information they're getting from family members. So that can be very helpful, but it depends on the individual. Some individuals don't want family members involved for privacy reasons and pride. So that can be difficult.
I think pride would probably be one of the first important.
Well, again, especially maybe for us men.
Yeah, for me, yes. Right. But now, and women might say, that's not anybody else's business but mine.
I hear that frequently. Yeah.
Yes.
Yeah.
Okay. As a clinical psychologist, what do you do in treating depression? How do you do this? How do you work with people? If somebody went to see you, Dr. Joel Shuy, how do you work with people for treating depression?
I think the first step is to provide accurate and good information. But in order to do that, I need to know a little bit about where they're getting stuck. And I'll often use phrases like, where are you getting stuck, right? Trying to not get too bogged down in clinical jargon or psychobabble. Where are you getting stuck, or what brings you here today? I'll start with something rather open-ended like that, and see where that takes me, and understanding what is going on with that patient, what the primary symptoms are, and then sometimes I'll also ask, what's your theory of why this is happening? What do you believe were some of the triggers, or what do you believe are some of the triggers? And a lot of times the patient will give you a much better diagnostic formulation and understanding of what's going on. I think too often that's an overlooked question. What do you think's happening? And like I said, sometimes I'll get really excellent ways of understanding what's going on with them. And then adding in the informational component so that to some extent normalize that the feelings that they're having are not that unusual, that we have some ways of treating this, and that there are many other people who suffer with similar symptoms. I'll get people will often be very tearful in the initial session when I meet with them, and that often comes from feeling demoralized that they weren't able to do more on their own to address their depression, and I'll try to normalize that. I'll sort of start out the session pointing out where the Kleenex are in the room, and then if they start to cry, I'll try to normalize some of this, because people feel as if there's something horribly wrong with them when we know this is a very common thing, which is why we have shows like this. It's not a normal part of aging like we talked about earlier, but at the same time, throughout the life cycle, many people will experience some degree of depression. So,
but I think it's also important for people to recognize, on one hand there's depression, on another hand there's grief.
Right.
And too many people mistake grief for depression. Right.
And that would be, again, another example of providing accurate information to somebody.
So you can make a diagnosis.
Right. And then often there's a friend or a family member saying, this is what my uncle is saying is wrong with me, or my children say this is wrong with me. And it's really helpful to then stop and ask them, well, what do you think is going on? And the people are really insightful, even when they're hurting and suffering.
Do you find that many people that suffer from depression are able to verbalize their feelings to the point where they start, through your help, can understand that the feelings they feel are normal feelings, that they're not abnormal, and there's no reason to be in a depressive state? Can people talk themselves out of this with good help?
Yeah, and it takes time. I think the research essentially points to the combination of medications and talk therapy or psychotherapy or counseling seems to work best. But some people do just fine with medication alone. I think the research suggests that you have shorter term. You may not have the long term benefits from that, and certainly a skillful psychiatrist managing the medications and knowing when to taper off or taper down is important. But the talk therapy part is critical, and that understanding that how we think affects how we feel and how we act. Certainly with cognitive behavioral therapy, which is probably the main tool that most psychologists work with. That's the emphasis. So there's some venting or catharsis of getting feelings out that's helpful. Having somebody listen and not be scared away is important. But also teaching people how we get into these patterns. The depression comes over people like a fog and starts to change the way they view themselves, the way they view the world around them. And it's important to help them figure out how to challenge kind of faulty thinking that goes on about themselves. We start to feel as if we are the depression. And I'm always emphasizing to people, you are much more than that.
So many people that are in a depressive state don't realize the problem that they really are having. Mm-hmm. It is a sickness. Mm-hmm. It's not something that just generally won't go away without some kind of treatment, like you point out.
Right.
Medication or a combination of medications and therapy, counseling therapy. But getting people to admit that they've got a problem and going to see a psychologist or a psychiatrist or getting the right kind of counseling help is probably the most difficult step of all.
People like to think that they can do it on their own. I think we all do. And we all like to think that we can work through things on our own. But there's also the stigma, the societal stigma that still goes with mental illness, and that people will think I'm crazy, people will think I'm nuts. I mean, terms like that are usually thrown around.
Don't you think, though, that we're sort of moving beyond that a little bit?
I think it's getting better.
It's better?
But certainly in some family systems, it's alarming that there's such denial and naivete on something that you'd think people would read about or hear about on the news, but it certainly is something that if people do get in, I think that if they can get into the first session, it's like if they show up, they'll be okay. I mean, like with the crying thing, I usually tell people it's more important to be able to cry than if you can't cry. I mean, it's nice to be able to turn the faucet off when it starts going. But again, that's part of normalizing their experience and helping them be comfortable so that they can talk about things. But I would worry about somebody who marches off to a mental health professional's office and is really eager and chipper to talk about things that hurt, are intensely private, and so some of the more painful things that are going on in their life. So people need some help sometimes getting in.
If they want to, how do they contact you all?
Certainly through the hospital at Wuesthoff. We have a behavioral health services program.
Okay, so if they just call the hospital and ask for behavioral services, they can get it. They can get to you.
Absolutely.
Okay, all right. We're out of time. And this is a topic that's very difficult to talk about in 28 and a half minutes. It's very difficult. But I hope that you've given our viewers a sense that if they think there's a problem, they need to seek help. And I want to thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL 1300 at 321-631-1300. And for more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. You can find out about all the shows that we offer for information purposes. Thank you for watching.